Welcome, Dr. James Fleshman. Dr. Fleshman is the Sparkman Chair and Professor of Surgery at Baylor Dallas, Texas A&M University. Welcome, Dr. Fleshman.
Thank you, Steve. It's good to be with you.
It's great to see you. You and I have been friends, I dare say, more than 3 decades, so always good to see you, even if only by video at present.
I agree.
I'd like to talk to you today a little bit about some of the college quality programs and what those programs mean to somebody like you who's chief of surgery and to your C-suite folks. What is the value of the ACS to hospitals and to hospital administration? And perhaps we could start by your outlining for us some of the programs in which you participated at Baylor Dallas and at Texas A&M.
Well, I'm proud to say we have the National Surgical Quality Improvement Program that we've participated in for over 10 years. That's very helpful. The administration really likes the fact that we are watching our outcomes and our quality. We have our trauma QIP and the trauma program certification for level 1 trauma. We have the Metabolic Bariatric Surgery Quality Improvement Program, and we're a Center of Excellence for Bariatrics through the college. We also have Commission on Cancer. We're in the process of getting our national accreditation for rectal cancer program reviewed and approved. And then we are in the process of accrediting for the National Accreditation Program for breast cancer. And the most recent thing that we've done has been we invited the American College of Surgeons with David Hoyt and Cliff Coe to come visit our hospital to look at the high reliability organization status of our hospital to give us a review. And that was extremely informative for our administration. They were wondering what value that was going to bring. And what it did was it made us rethink everything that we were doing. The healthcare improvement group, the health information management group, the quality best care group all got together and started talking together. And because of it, we've actually revised how our communication goes and who does what and where information transfers back and forth, and created 2 new committees within the hospital medical staff to help us with our culture of safety and culture of quality.
Was your administration receptive to the idea of adding another quality program and 2 more committees?
The 2 committees came from internally after the review. So our medical staff started to realize that, whoa, we need to focus a little more on specific quality improvement projects and specific efficiency projects. Then the administration was extremely receptive to the idea that we wanted to review our quality program. They have always participated in a STEEP program here at Baylor Scott & White system. That's the safe, timely, equitable, efficient, effective, patient-centered care program. And what we didn't know was how we were actually doing and who was doing what. And we had this huge program of quality, but there was no traceable, definable organizational structure. And that's what made us do this in the first place. When we first started NSQIP, I did hear, oh no, another quality program that I'm going to have to pay money for. But what happened was in 2013, we were a little off on our surgical site infections in colon and rectal. We went and we used our NSQIP data, created our bundle, used the NSQIP data to review ourselves, and we're back in the exemplary status. So they started seeing the benefit of routine review of outcomes and for surgeons to see their own data. I think that's been an incredible improvement.
So it sounds like the C-suite are happy because the results are improving, which is going to translate to a better functioning system. What about the medical staff? How do the surgeons in the various areas feel about supporting the programs in terms of, do they need to be coaxed, or are they kind of excited to begin with, or is it a mix?
Well, there's three different areas. One, the National Surgical Quality Improvement and the TQIP give us our data, and every surgeon in our institution likes to see their data and where they stand relative to the rest of the nation. And when they're not in the good area, it's an immediate response to let's get in the good area. And they're really proud of it when they can see that they're exemplary. The second thing is the national accreditation programs around the Commission on Cancer area, the rectal cancer and breast. It took us a little while for people to understand that doing multidisciplinary team management of patients was where the future is. But once they realize that you get your data back by being part of that program, in other words, you get to see your rectal cancer specimen on the screen compared to someone else's, you get to see what your circumferential radial margin rate is, you get to see what your patient outcomes are compared to everyone else, and they start getting invested in what's going on. Same thing with breast. And then finally, what we did was we took the concept of a multidisciplinary team and wrapped it into the high-risk complex surgery process, where every hospital in our system has to have certain resources, certain surgical input, certain multidisciplinary input to be able to do those cases in their hospital. It's much like the high-risk complex GI surgery that David and Cliff have brought to the esophagus, liver, and pancreas group. And we're doing that. And so now all those little one-off surgeries that have been done out in small hospitals in our 50 hospital system are stopped, and all that stuff is coming into our flagship hospitals, or the hospital that has designated themselves as a pancreas center or an esophageal center or a chest center to do lung cancer. And the outcomes are going to follow that. But right now we've seen that the decrease in those onesie twosie operations has been very good. And I think patients understand it and appreciate it. They have a multidisciplinary team working for them, and it works.
At what point do the residents, fellows, medical students get involved with these programs so that when they graduate, they understand the importance of ACS certification wherever they go work?
So our residents are intimately involved with the multidisciplinary team process. They present our patients, they collect the data that gets put in, they see the data as it's collated, and now they actually have the ability to do research projects based on contemporary data. They like that. They feel like they're really at cutting edge when they're participating in that. Students are slowly understanding that multidisciplinary team care is the way of the future. And I think that as this goes on, as we have expansion of the teams, they will actually understand that that's the best way to go. It protects the patient. It's all about patient-centered care. It's all about improving outcomes. You know, we elected to have targeted procedure NSQIP. So, and we chose rectal cancer, proctectomies. We chose colectomy for cancer. We chose lung resection for cancer, esophageal resection. So those patients actually get double scrutiny. They get their multidisciplinary team, and then they get their NSQIP reports, and the two merge. And so now you're not having to function solely as a data collector at the multidisciplinary team because NSQIP's backing you up.
Excellent. That's a very good point of the synergy among the programs. You mentioned patients, and of course it is all about our patients and improving quality and optimizing quality. What do the patients know about these programs or the data collected from them? Is it shared with them in any way? And if so, how?
We tell our patients that we're putting them through a multidisciplinary team review before they get treated or operated on or during follow-up. So they know that we're following them. We started out in the National Accreditation Program for Rectal Cancer thinking we should send the patient the report, but we became concerned, at least the executive committee of the NAPRC became concerned that the patient might not understand what we're saying. So we started sending that back to the referring physician and asking them to explain it to the patient. But we're pretty sure the patient appreciates an upfront multidisciplinary review, gets multiple consults without having to go to every office to get it.
Yeah, and the work you've done with the NAPRC since 2011 is formidable. You're obviously one of the founders and co-chair of the executive committee and the entire program, and your former hospital, I guess, was site visited as well. So people are engaged, people are up to speed. What do you see down the line as needed for additional quality programs? Where do you think the college could spread out? You mentioned advanced GI.
Well, advanced GI right now is only covering liver, pancreas, esophagus. What I think is needed is gastrectomy, carcinomatosis, possibly things like pelvic exoneration for pelvic tumors. Those are fairly rare nowadays, but still they would benefit from a multidisciplinary approach. Now, whether they can fit into one of the existing programs, if pelvic exoneration went through NAPRC or gastrectomy went through complex GI, those would be appropriate, but I think we would apply the same standards that have been looked at. And the standards are all around the resources that the hospitals should apply to the treatment of those patients. Well, if you think about it, you're going to have an ICU, radiology, radiation oncology, medical oncology, and surgeons. For the other groups, you might as well add that into these new ones that are going to come on board.
You mentioned multidisciplinary, and that is the crux of everything done in virtually every program, even trauma. We rely on our colleagues in other areas. These are all programs administered by the ACS, either directly or through the Commission on Cancer, such as the NAPRC. How do you get people enthused and engaged who are not surgeons? So you have radiation oncologists, medical oncologists, pathologists, radiologists. What's the trick to get them excited about participating?
We spent a lot of time talking this through when we first started because, and I don't want to call one particular specialty out, but there was some pushback that, oh, I'm not getting paid and this is extra time on my part. But as time went on, they started seeing that the discussion that went into the care of each of those patients was outstanding. Half of the time, they would get a referral out of it without having to see the patient first. And then finally, your altruistic side starts to rise to the top when you're really doing the right thing. And it was very satisfying to see the contributions that came out of our specialty colleagues. They actually started realizing that this was something that set Baylor University Medical Center apart, and they became ardent supporters of what we're doing, and they show up, and they're on our executive committee of our NAPRC, and they want to hold us to to the standards, and that's great. I think that's good.
Well, you didn't want to single out any especially. I'll single out one person, Greg Prisco, who you've got down there. Is one of my favorite radiologists for rectal cancer, imagers, I suppose, for rectal cancer. You know, gives a great talk, shows wonderful data. And I guess when you have one person like that, it becomes contagious in a good way, and other people join on.
Well, he certainly influenced the rest of the specialties in our institution, because his enthusiasm is unbelievable. And if you've never had him read one of your x-rays for you, it's like, okay, why don't you just go ahead and do the operation, Greg?
Yeah. I enjoy talking to him, and I've watched him with the images. He's really a wizard. It helps a lot. Thank you very much, Jim. It's really great to see you and to talk to you, and the support that you have and that Baylor has, and Baylor Scott and White, Texas A&M for the ACS programs is laudable. And I encourage people who are viewing and listening whose hospitals are not as engaged to listen to what Dr. Fleshman said and to get engaged, because it does benefit us, because it benefits our patients.
But before I get off, I have to thank you for your leadership, Steve. This has been your work, your specific focus with the American Society of Colorectal Surgeons, on the regents of the American College of Surgeons, and with the Commission on Cancer. And I applaud everything that you've done, and I thank you for letting me actually be involved. So it's been a good time working with you.
Well, thanks, Jim. It's not letting. I mean, you've been there the whole ride with me, as I said at the beginning, and you know, it's a partnership, it's a team, and we do a whole lot more together than we would individually.
So, well, thank you. I appreciate that.
Okay, best to Linda, and looking forward to seeing you in person.
Tell Mariana hi.
Thank you.
See you later.
Bye.
Bye-bye.